going to go to here, and we're going to go to here. What is going on here? There we go. And let's switch settings. Swap. And why am I doing what I'm doing? Okay, are you? No, you're not seeing the right screen. Oh my goodness, I can't get anything right today, people. There we go. We're better now. Okay, Facebook community. Welcome. HCMA participants in the Zoom room. Welcome. So sorry about the little late start and the technical difficulties tonight. We will be streaming on Facebook while we are doing our Zoom room. If you'd like to join the Zoom room, I'm going to ask Julie or Amy from our team to go over to Facebook and drop the link onto the Facebook page. So those who would like to ask questions can just pop right on into the Zoom room and ask questions. Tonight's broadcast will be recorded and it will be placed on the website later, as well as our YouTube channel. For those of you who are watching through Facebook, welcome, but we're not taking questions from Facebook, so you will need to join the Zoom room to ask questions. At the conclusion of tonight's session, I will repeat this again. We will stop recording. We will stop streaming on Facebook to allow for private questions to be asked. So we are starting with a very small crowd here today because of our glitch, but we're going to start with some very basic introductions. Julie, who just ran away from the screen, is HCMA's volunteer coordinator. And she will be the one to help you if you are interested in volunteering for the HCMA. And Amy Mann is back in action as our meeting coordinator, and we are happy to have her back with us tonight. And those are the two staff members from the HCMA that are here tonight. Tonight we are going to Nashville. I wish we were there in person. Instead, we're in New Jersey and California and Pennsylvania, where it's probably a little bit warmer where you guys are. So Dr. Mark Zenker, I can recall the first time I met you, you were sitting a row behind me in a conference, and I said, whoever that guy is asking those really smart questions is somebody I need to get to know. And I literally think I said those words to you. So welcome.
I think you did.
Welcome to the Bighearted Warrior Tour. So happy to have you here, and really excited for a nice night. And Mark, why don't you introduce us to your team?
Well, thank you very much, Lisa. And yes, welcome from Nashville, Tennessee. So we are very excited with this partnership with the HCMA and Lisa, and have been a center of excellence now for, I think, about 4 years. And this is the first time that we presented in the Bighearted Warriors Tour. So I am the director of the St. Thomas Heart, HCM and Cardiac Amyloid Clinics. We are part of Ascension Medical Group through St. Thomas Heart West. And here is our phone number, 615-269-HCM5. Unfortunately, HCM 1, 2, 3, and 4 were all taken. So all we have was HCM5 or 4265. And this is our email, mark.zenker@ascension.org. And this is our address of our center. So this is our team at the St. Thomas West HCM Clinic. And we are featuring these three members on the lower panel. And I'm really very excited about the educational offering that we have tonight. Dr. Tom Bartlett is one of our electrophysiologists that will talk about an ICD from a patient's perspective. Annie Rodonski is the PA for our HCM clinic, and we'll talk about CHF as it relates to hypertrophic cardiomyopathy. And then Dr. Ronald Salomon, who is a psychiatrist with our group, will talk about mood as it relates to cardiac disease with hypertrophic cardiomyopathy. So I will start with my talk, and just briefly, I'll introduce myself. I was born and raised in the Midwest. came to Nashville, Tennessee at Vanderbilt University Medical Center and did most of my training there, was on faculty as assistant professor of medicine for about 3 years, and then moved my practice to Ascension, St. Thomas West. Started an HCM clinic about 7 years ago, and did this in part because I have an interest in the field. Have actually, my father-in-law has had HCM and had to navigate my own family through genetic testing and evaluation. And in addition, then Andy Rodonski joined my group about 3 years ago and has really been a big asset. So I'm going to talk about today is, can we cure hypertrophic cardiomyopathy? And this is a futuristic talk, but one that I think is important because it gives us some goals for the future. So if you look at the very first description back in 1957 by Dr. Donald T. Eyre, he was a pathologist, a British pathologist, who was perplexed by 8 cases in young individuals that died suddenly, and did autopsies on these individuals and found that they had what he thought were even tumors in the heart. In the end, we found this was actually hypertrophic cardiomyopathy. And if you look at, this is a specimen of one of these unfortunate young men, and this would be the normal thickness of the heart here, and this is this massive hypertrophy of the myocardium, and this is very sine qua non of hypertrophic cardiomyopathy in the most common phenotype. And what he found under a microscope is that if he looked at hearts with HCM, normally these should be very parallel, very organized fibers. What he found instead was this disorganized, called myocardial disarray, that is also very a part of the pathology of hypertrophic cardiomyopathy. So since that time, we've been trying to figure out why is this and what is the reason for HCM. It appears that it's the cardiac sarcomere. And think of these sarcomeres as little motors in the heart. There are millions of these in the myocardium, and there are 2 little protein pistons called actin and myosin. And these actin and myosin rods move back and forth and are part of the little motors in the heart that cause the heart to beat. Unfortunately, in hypertrophic cardiomyopathy, it's sort of like the accelerator in the car is stuck in the on position, and this is a heart in hyperdrive. And this wastes energy, it's very inefficient, and as part of that leads to thickness of the heart muscle and several other problems such as chest pain, shortness of breath, and even heart arrhythmias. So again, remember this actin and myosin proteins, or these pistons, because we'll talk about this in just a minute. But this is where this disease resides in the heart, in the sarcomere, or these little motors. We have subsequently found out that depending upon your phenotype, anywhere from 40 to 50% of people have a single mutation that causes this disease. And there are actually 8 total main mutations. The 2 most common are myosin binding protein C and myosin binding heavy chain. And we now know where most of these monogenetic or single genetic mutations come from that cause this myocardial disarray, hypertrophy, and some of the consequences of this to our patients. Now, again, I'm talking about how do we cure this disease? We have made remarkable strides in doing what we've done so far before we even talk about cure. And if you look at this paper by Dr. Marin, this looks at the mortality or death rate. Initially, back in the 1970s and 80s, we thought the death rate was very high, 6% per year. When you then look at HCM cohorts, we began to formalize HCM clinics. We found that the mortality could be less than that, around 1.5% per year. Now that we have things like internal cardiac defibrillators, heart transplantation, myectomy, defibrillators, hypothermia protocols, we now have contemporary treatment mortality down to 0.5% per year, which is about the same as the general US population. So we made remarkable strides, but people still suffer with this disease. And depend upon your profile, this may be a journey that many of you have taken with hypertrophic cardiomyopathy. The majority of people have a benign, stable course and live a long, healthy life. Unfortunately, several of our patients who come to see us have issues such as sudden cardiac death, which we can predict, but not 100%. Some people have progressive heart failure from obstruction, the thickness being so thick it causes impedance to the pumping ability of the heart. Now, we can treat this with medication and even septal reduction therapy that we'll talk about in just a minute. Some people have a journey towards advanced heart failure, which is a challenging thing to treat. We do have options for this, but these are the non-obstructive patients that don't really have the surgical therapies available, but can have transplantation in extreme instances. Then there are also people that have things called atrial fibrillation that can lead to stroke. So again, despite the advances we have made, we still have some real challenges. Well, what medicines do we have now? Well, we have beta blockers, and several of you are probably on these. Names would be things like atenolol, metoprolol, bisoprolol, nadolol. These are drugs we use in other cardiac conditions. And what they do is they slow the heart rate. They slow this overactive, inefficient, pedal that's stuck in the on position on your car. They improve diastolic filling. They relax the heart. They decrease gradients for obstruction, and they improve symptoms. This was just studied actually in HCM patients by Dr. Dybro in a 2021 article. And he found that if we gave a patient with HCM 14 days or 2 weeks of therapy, we could indeed lower gradients or lower obstruction or resistance. We could make them feel better, but unfortunately, we couldn't increase the exercise capacity. Now, why is that? Well, these drugs, if they slow the engine too much, they can sometimes actually slow the output of the heart. So we can improve symptoms, but can't always make people exercise or do more activities, which would be our goal. But beta blockers can help. Well, what are smarter medications? Well, enter the smart pill. There's a medicine called Mabacampton. It's not yet been FDA approved. We hope that it will be sometime this year. And this is now a more specific drug to the cardiac sarcomere. Remember the actin and myosin fibers in that little motor that we talked about. Well, this problem is where there are too many actin and myosin cross bridges between these pistons. And what this Mabacampton does is it directly relaxes and makes less of these cross bridges, and by relaxing the heart, improves the function. We can then decrease the obstruction. We can improve symptoms. But again, this is a drug that's not yet approved, but is probably a smarter solution than was just the beta blockers. So if you look at the therapies we have now, and this was a nice article by Dr. Marty Marin, and he looked at different therapies that we have versus obstruction. If you look at this y-axis, these are the percent of patients that still have obstruction above 30 millimeters of mercury. So you'd like to have all these therapies make this zero, but that's not the case. With beta blockers that I talked about, 88% of people still have high gradients. Take disopyramide, which is a medicine that some of you may be on. It's a more potent relaxer of the heart than beta blockers. Unfortunately, you have to take it 2 or 3 times a day. It also has several potential side effects, but even that, 60% of patients still have excess obstruction or gradients. This Mabacampton, which is not yet FDA approved, but I think will be soon, even that, 43% of patients still have high resistance to flow and suffer from symptoms. We can then progress to septal reduction therapy, and if people have significant life-altering symptoms despite medical therapy, things like alcohol septal ablation and surgical myectomy are options. And truly, myectomy is the gold standard treatment. Only 2% of people in this trial had significant resistance, but not many people come into my office wanting to get a myectomy if there's another alternative. So what could that alternative be? Well, enter the concept of gene therapy. When I was at Vanderbilt, I had an NIH grant to study gene therapy in heart disease. And there are several contemporary therapies now where gene therapy exists. Things like thalassemia, sickle cell anemia, Friedreich's ataxia. There are several gene therapies now that can be done. And what I'd like to propose is that maybe this could be done in hypertrophic cardiomyopathy. And this is what people are studying. To understand gene therapy, you have to understand genetics. So again, genetics is basically DNA. Think of DNA as a blueprint in the body. So if you're building a house, you had an architect, you hired an architect to get a blueprint. That's what DNA is. And the proteins are what are the building blocks for that house, in this case, for the body. And there are, millions of and trillions of genes in the body. Each of them has a nucleus. Each of them has a DNA and a blueprint for then making proteins. So again, this is something that just to understand that there are DNA, and this is a blueprint for the protein making and building blocks of the body. What are the function of genes? Genes do everything. They make structures. They make muscles, bones, cartilage. They help direct the body to do things, grow hair, flex muscles, etc. They also support bodily functions, the immune system, circulatory system, the brain. Everything runs by genes and that blueprint. But if these genes are defective, like they are in a significant proportion of people with hypertrophic cardiomyopathy, they then can lead to bad proteins, bad building blocks, and then, in this case, HCM. Well, what is gene therapy? So gene therapy is the concept of getting a healthy gene, which we can actually grow in the lab, get that healthy gene and piggyback that into a suitcase, and then get that into the body. Well, what is the suitcase? Well, believe it or not, virus vectors are the best suitcases to do this. Now, viruses have a bad name right now, right? With COVID-19, for 2.5 years, we've been suffering from the ravages of COVID-19 viruses. But there are so-called friendly viruses, and this is an adenovirus, where you take out the part that makes you sick, but use the advantages of that particle as a suitcase to deliver the healthy gene to the body. And again, this is being done now in several diseases, not yet HCM, but I think there's a future for this therapy as a curative one-time therapy. There's now even a journal called Gene Therapy, which is published twice a month, that is dedicated just to gene therapy for human diseases. This is really an exciting, I think, thing in the future for our patients. Well, how could we do this? This was a really nice article written by Dr. Helms, sort of looking at how do we basically do gene therapy. So it depends on what's wrong with the gene. If there's a single gene variant, like in most people with HCM, there could be regulatory gene variants or maybe multiple genes that don't work. We have to figure out what therapy we need to do, deliver that, and either shut off the gene that's making bad protein or turn on the gene that should be making more of the good protein. And then by doing that, these can then give life-altering effects to people with multiple diseases, including hypertrophic cardiomyopathy in the future. So there are really 3 different ways to do this. One is to, if the gene itself has lost function and there's reduced good protein, we can package this with, in this case, an adenovirus, make that the suitcase, deliver this by IV, deliver it directly to the heart, like through an angiogram, and can give this to replace the bad gene. If there's a gene that's making abnormal protein, we can actually silence this particular gene, turn that gene off, and this can be done with so-called lipid particles, little fatty particles that we use as suitcases for the gene therapy, or again, the adenovirus, give that to patients and cure the disease. There's also something called CRISPR, which is a gene editing therapy you may have heard of in the newspapers. And this is basically a way then to edit the bad gene, change the blueprint, and make it so it's a good gene and makes the kind of therapy we need to make the good proteins and then help people with diseases that are gene-based. So again, this is a futuristic talk. This does not exist right now for HCM, but I think it's around the corner. And if you look at, in 2021, there are 2 different companies now working on gene therapy for HCM. The one is a company called Tenaya, and they've actually found a product called TN201 that works for the myosin binding PC3 gene, the most common gene mutation that we have in HCM. And they found, at least in the mice, in a mouse model, that this can be done safely, can actually reverse HCM. And after 1 year of therapy, there's been no ill effects and there's been retained therapy. They have now gotten FDA approval to do further testing. And eventually, of course, we want to do this in humans. There's another company called Alexio, which has looked at a cardiac troponin mutation called TNNI3, which is a common mutation in HCM. And they have also shown, at least in animal models, that this does work and may be a permanent therapy for HCM. So again, preliminary work, I think very exciting. And I would highly encourage those of you with HCM, when these trials come about, think about this and think about this potential therapy as something we can have in the future. I'd like to thank you for your attention. And again, in summary, we've made some real strides in HCM over the last 60 years. I think we can make more strides yet. And I also think that gene therapy may be a curative option in the future. And we'll have to see what comes to fruition with those two companies. And hopefully within years to come, we'll have a curative therapy for this disease.
Thank you, Dr. Zenker. Just so everybody knows, Lisa had to leave for a little emergency, but she hopefully will be back soon. So the next speaker would have been Lisa, but now we're going to go to Dr. Bartlett.
Great. Well, while Dr. Bartlett's getting ready, let me announce him. So Dr. Bartlett is a friend and colleague. He's a cardiologist and electrophysiologist, and you really don't realize how smart your friends are until you read their CVs. Dr. Bartlett did his undergraduate training at Columbia University, then did internal medicine residency at University of Alabama, and then went to the National Institutes of Health. If you remember the story of Dr. Braunwald at the NIH in the 1960s, who really discovered the initial treatment and way to diagnose hypertrophic cardiomyopathy. He was also at the NIH. And then Dr. Bartlett went on to Harvard at the Brigham and Women's Hospital and has been a partner at Ascension, St. Thomas West now for about 14 years. So Dr. Bartlett, if you are ready, we're eager to hear your talk.
Mark, I am ready. I think you have to unshare your screen so I can start sharing mine.
How about that?
Just in the meantime, if anybody has any questions in the webinar, please type your questions in the Q&A box. If you're watching us on Facebook, you have to register for the webinar to be able to ask questions. So just a little reminder, we love questions. So take it away, Dr. Bartlett.
Again, I need to be able to obtain the share screen function. And
so I just gave you a new share. See if that helps. Hold on just a second. How about that?
That'll probably do it. We're going to talk tonight about the situation where your doctor has said to you as a patient that you need a defibrillator. I am not going to walk through the decision-making process that got you to that point. That's Dr. Zenker's department. I'm going to assume that you've been told you need one and now you're kind of biting your nails wondering what's going to happen next. After all, this is a relatively life-changing decision and process in some ways. So to begin with, if your cardiologist, your hypertrophic specialist says you need a defibrillator, you will go to see a cardiac electrophysiologist. At St. Thomas West, we have 6 of them. They're all excellent, well-trained, and any one of them is capable of carrying out the steps which we're going to discuss. The indication for hypertrophic cardiomyopathy patients to go on to have defibrillators is basically pretty simply stated. Cardiac tissue has abnormalities that can lead to rapid and unstable heart rhythms. When that happens, the heart does not pump properly and circulation collapses. Although we have medications that can help prevent that from starting, at this day and age, once that process begins, there's really only one therapy that works, and that's a shock delivered externally or internally. The likelihood of your getting an external shock is pretty small, so we try to predict ahead of time who might need such a life-saving shock, and then implant defibrillators in anticipation of what we hope will never happen. I try to get patients to think of it as life insurance, not to think of it as something that is inevitably going to be needed, but as something to be there in the situation where the worst happens. So the process begins with the consultation with an implanting physician. Generally speaking, most electrophysiologists are trained to put in devices such as defibrillators. There are fairly standard operative procedures that are undertaken to do this. It is not as if there are many variations on the implantation. It is a fairly straightforward thing to do. You would want to make sure you're talking with someone, however, who's done a fair amount of it and has years of experience. After the consultation, where the physician will describe the risks and benefits of the procedure, the actual nuts and bolts of what to expect on the day and follow-up, you'll then go for the implantation itself. In most situations, the implantation is a same-day procedure. The patient comes to the hospital, gets it done, goes home, and has a fairly brief time of recovery at home. Happy to describe that in more detail, but in our institution, we ask that you keep the incision site dry for a week, not lift the arm of the side the defibrillator has been implanted on for 2 weeks, but after that, life goes on with very little interruption. Following the implantation, there are follow-up visits. And again, in our institution, we ask that you come see us in about 2 weeks so we can inspect your incision, make sure it's sealed up properly. We ask you to come in for a first programming visit in about 3 months, and then come in for the defibrillator office testing every year thereafter. One of the nice features of the modern defibrillator world, if you like, is the development of what we call remote monitoring. Beginning about 10 years ago, we had the capacity to provide patients with a little box we call a remote module to take home. The remote module then actually can be left pretty well alone in the patient's bedroom, plugged into an electrical outlet under the bed where it can't be seen or anywhere else of the patient's choice. And every night that monitor makes contact with the defibrillator, interrogates it for any developments that might have occurred, and we'll describe that in a minute. And then in the event that something noteworthy has occurred, makes contact with the local cell phone network, sends an internet message to our monitoring system, where we are now then enabled to call the patient the next day with a report as to what happened and to arrange further care with the patient. Annual visits I've mentioned. There are some tests that have to be done on an infrequent basis. Once a year has turned out to be perfectly satisfactory. Now, in the end, the defibrillator won't last forever. The modern devices last on the order of 10 to 12 years, but we expect our patients to go through several of them in a lifetime. The replacements performed at the end of the battery life of the original device are quicker than the original implant. It is simply about a 30-minute in and out with very little discomfort, and the process continues. There are different types of ICDs. An ICD is just my simple acronym for an implantable cardiac defibrillator. So I'm going to use that because defibrillator's got lots of L's in it, it's hard to say. A single chamber ICD has basically one lead. You can see in this diagram, I have illustrated a 3-wire defibrillator. And although there are some defibrillator patients who need the 3-wire systems, most hypertrophic cardiomyopathy patients who need defibrillators need 1 or 2 wires. If you look carefully down in the bottom of the illustration, you will see a line, a label for something called the right ventricular lead. In a single chamber defibrillator, there's that one lead going up through the veins to the device itself, which is typically placed on the left side below the left collarbone. In some cases, we would like the patient to have an atrial lead as well. In that case, you would see the second lead on the illustration, also implanted. That process adds all of about 10 minutes, maybe less, to the overall procedure. In rare cases, restricted to patients who have had the development of congestive heart failure, we would add a third lead called the left ventricular lead. Again, that is more commonly used in non-hypertrophic cardiomyopathy indications, but there are some patients where there is the development of heart failure and the third lead is recommended. This is an attempt to give you a sense of what we're talking about. There are, depending on who you include, 3 to 4 major manufacturers of defibrillators in the United States. In the interests of equal time, I've tried to give you a picture of one or two from each of the major manufacturers. You can see, relatively speaking, the size of the device in a patient's palm. And for the purposes of illustration, in the middle picture, you can see what a defibrillator right ventricular ICD lead actually looks like. I have tried to give you some representative measurements of weight and dimensions in the middle item on the left-hand side of the slide, where the typical measurements are illustrated. Although there is some variation from device to device, there isn't much. And so 80 grams is approximately the weight. And you can see that a typical size is 2.5 inches by 2 inches by a 1/2 inch thickness. The devices are implanted in a procedure room. You come to the hospital, we take you into our pre-procedural holding area. There you will be asked about 1,000 questions by very attentive and compulsive nurses who are doing just what we want them to do to make sure that you're ready for this, that you've had all your questions answered, and we're not making any errors about medications that should have been held, etc. You'll get wheeled into the room after you've met our anesthesiologist. At St. Thomas, where I happen to do my work, we have a dedicated group of anesthesiologists that supply nurse anesthetists in the actual procedures. The anesthesiologist drops in from time to time. These people are very expert and are actually a real asset to us in our program. They will administer intravenous medication. We almost never use general anesthesia requiring intubation and ventilation with gas. It simply isn't that big a procedure. The patient's put on the table, actually will cooperate with the staff while we attach some EKG patches. The patient lies down, the sedation is started, and the nursing staff will then apply antiseptic to the skin, and then towels and sheets to create a sterile field. The patient's completely covered except for the face. That is available to the individual providing the sedation. And here's a little illustration of what the surgical site actually looks like. In this particular illustration, the operator at the top has administered local anesthetic, although the patient is already sedated and does not feel the anesthetic going in. A small incision is made. In the lower illustration, rather than take you through all the steps, we are now looking at a dual chamber defibrillator where 2 wires have been implanted and attached to the generator. You can see the incision. At the bottom of the incision is a small pocket that's been made just large enough to accommodate the generator and the excess lead, which is coiled up loosely behind the generator. The generator resides on top of the pectoralis major, which is to say it does not go below the major chest muscle. The defibrillator essentially sits below the subcutaneous fat. The screwdriver you can see in the doctor's hand is actually used to secure set screws that pass through the plastic header of the device and actually secure the leads to the device. When the device requires replacement, that screwdriver is used to reverse the header screws. The leads are detached from the generator. A new generator is attached to the old leads and placed in the same pocket. Here's a picture of some ICD leads. I actually think that this is the most impressive, one of the most impressive parts of the technology. If you think about it, these leads are flexing inside the heart with every single beat. Now let's take a step back and talk about what a defibrillator actually does. When the patient experiences a rapid heart rate, and rapid is defined typically as something over 200 beats a minute, although that is an adjustable number, the signal passes up through the defibrillator lead into the generator, which counts the number of beats per minute. And when it sees that the rapid rate has been sustained for more than 6 seconds, the device goes into work. It sends the battery in the device, charges a capacitor, which then delivers the shock from the can, which actually acts as the positive electrode of the current flowing through the chest. And the lead itself acts as the second electrode. You could think of it as the negative pole of a battery. If you look at the leftmost panel where you see where the letter B is, you will see that there is a sort of a spring-like wrap around the outer surface of the lead. That is the actual shocking coil. That is the electrode that provides the other side of the current, where again the negative electrode, where the can itself is the positive electrode. If you look at the illustration to the right, where you see cross sections of the leads, you can see that what's involved are small little tiny filaments running through an outer wrapping of plastic of various types, very sophisticated plastics, and that the innermost lumen of the lead is hollow inside the green wrapping. So the lead is what's called coaxial. There is the inner hollow lumen. There is the green wrapping. There are the cables that run lengthwise from the defibrillator all the way to either the lead tip, which is where sensing of signals occurs, or to the coil where the shocking occurs. In panel A, you see a single coil defibrillator lead. In panel B, you see a cross section of a dual coil defibrillator lead. That is more of historical interest as the industry has tended to move away from dual coil leads. The bottom panel below the two cross sections show the suture sleeves that are used to retain the device. In the pocket which I showed you earlier, as the surgeon was putting the defibrillator through the incision, there are actually little tiny sutures that surround these plastic sleeves. Different sleeves manufacturers have chosen different designs, but a little tiny suture goes around the plastic sleeve to hold the lead in place up in the shoulder. And that's where one end of the defibrillator lead gets anchored. The other end gets anchored in the muscle of the tissue. You can look over again, you can see that in panel B in the lower left, there's a little tiny screw extending out from the tip of the lead. And in the X-ray in the middle, on the bottom X-ray panel, you can see that little screw extended. How that works is technical, but it turns out that hollow lumen actually rotates, and as one turns a pin at the back end of the lead, the helix extends into the muscle. This is all a bit mysterious to the average patient, which is why I've taken some time to explain how the leads actually work. There is a different type of defibrillator called a subcutaneous ICD. These have a particular set of strengths and weaknesses. There are times where there is an advantage to placing a defibrillator outside the body, or more accurately, to put the defibrillator lead outside the intravascular space, outside the veins. The advantage of this particular device is that the lead is not in the bloodstream, and it is less likely to fracture over time. Lead fracture is a minor problem, but does have to be considered as one of the reasons why we have patients come in annually. The disadvantages of the subcutaneous ICD have been that the battery life has been less because it's more difficult to defibrillate with these kinds of leads. They cannot provide pacing because the defibrillator lead lies outside the heart, doesn't actually make contact with it. I should say as an aside that modern defibrillators have the capacity to act as pacemakers as well as defibrillators with the standard defibrillator that I've shown in the previous slide. The subcutaneous ICD has specific uses, and we'd be happy to discuss whether it's appropriate for you during your consultation. Most patients do not choose to have these implanted because of their disadvantages. The final result is seen here in this particular patient who I think is smiling, not grimacing. He will have a small incision with no visible sutures. The leads have been threaded through the veins using fluoroscopy as outlined above. And in the end, that's all there is. This is an X-ray that shows the a standard single coil, single lead defibrillator with the tip of the defibrillator extended in the right ventricle, as you can see at the very bottom of the X-ray. You see that white rectangular looking structure, that's the shocking coil. The lead itself looks fairly thin and hard to see, but you can trace it up from the base of the heart through the great veins to the defibrillator pocket. And then the defibrillator itself lies there. One sort of tidbit for the engineers, the defibrillator is actually about 50% by volume battery and about 40% capacitor, and then about 10% circuit board. To move on to the remote monitoring part of the long-term care with the defibrillator, you can see the different device remote modules by company. As I said earlier, you take the module home, you plug it into an electrical outlet in your bedroom. About 1, 2 in the morning, it will make direct contact with your defibrillator in a silent wireless process. The module is looking for evidence of problems with the defibrillator system, almost never found. It does also report to us if you have dangerous or not so dangerous, but still abnormal rhythms. The defibrillators have logging functions and are capable of retaining memory of any arrhythmias you might have, and those get passed from the defibrillator through the remote module to our office as often as every night, although that's very unusual. Every 3 months, the module will send us an all clear telling us that everything's fine and that nothing's happened. As the battery in the defibrillator gets close to the end of life, the module will also report to us when the voltage has reached a low enough level that replacement is necessary. These are programmers that get used when you come in for your annual visit to test the defibrillator. There are features of the defibrillator system that can only be tested in the office. It takes about 5 minutes to run a complete test. There are many features of the defibrillator that are reprogrammable. We don't have time to go into those tonight, but suffice it to say that the systems are very flexible. There is one set of features I think that's worth mentioning. It is true that not all ventricular arrhythmias have to be terminated with a shock through the chest. Instead, about 40% of ventricular tachycardia can be terminated by pacing by the device in a process called antitachycardia pacing. It's completely painless. It is unknown to the patient that it has happened. The defibrillator programmer is the way we set up antitachycardia pacing and adjust its features when necessary. So once a year, you'll come in, you'll get this device, these programming computers to interact with your device, and a full shakedown is done. When it's done, you're on your own. You get back to your life. You can forget that it's there. You know that we're watching it for you, and you live happily ever after, knowing that you've got life insurance in case you ever need it. Thank you for your attention.
Thank you very much. And I'm back. And I need to take this moment to pause and say HCM is very real and very unpredictable. As we began tonight's session, I received a phone call from my daughter's phone number, but it was her girlfriend telling me that my daughter had just passed out at a restaurant around the corner from my office. Knowing that her defibrillator was in place and that she is a well-managed HCM, I did not completely and utterly panic, but I had to walk very quickly. All right, I ran 2 blocks away to find EMS standing by my daughter's side. We were able to get her physician on the phone. We are going to download her device tonight. Her father came, took over, and let mom go back to work. I would be lying if I told you that it ever is an easy phone call to get. But I will also tell you that it's awfully reassuring to know that my daughter is protected with an implantable defibrillator and that she was safe, even though she was scared and scared the crap out of her mother just now. So I retained my title that I have self-appointed as the president of the I Hate HCM Club. And that is why I do what I do, so that someday my daughter doesn't have to fall over in a restaurant because she gets hypotensive, which I think is what happened. And we'll find out about the device later. So back, and HCM is very real and palpable in my life every single day in every single way. I'm so sorry that I threw off the agenda this evening, but I'm going to retake my position as question asker. And Mark, my deepest apologies that I literally ran out while you were talking. But there is a question to you, and I don't know how to phrase it any other way, so I'm going to read the question. Is genetic therapy just for the 40 to 50% of patients who have a genetic basis of their HCM, or is it possible for others that are not genetically based or at this time? So I'm guessing you were talking about gene therapy through Tenaya and others, and those things. I don't know if you want to jump into that question.
Yeah, so that's a great question. So we talked about the fact that depending upon where your thickness is, about 40, maybe 50% of people we can prove now have a gene disorder by our contemporary genetic testing. So yes, those are the ones for which right now gene therapy would make the most sense. Now, what I think is interesting about that 60% of patients that don't have a positive gene test, I think what's going to happen is we're going to discover several things about them. And what we know so far is that what we'd like to do, if I had a lot of money and time, is take everybody's genome and look at all their genes. But right now we can't do that because that's too laborious and expensive. So what we do instead is we do these commercial genetic panels that look at about 98 different genes. And those are the ones we know about that cause it. But there are people that have their own private mutations that we aren't smart enough yet to detect. So we may yet know that in the future to be the case. The second thing that we are discovering about these sort of non-genetic, quote unquote, patients is that several of them have multiple genes. So it's a more complex disease. The other is that there's something called epigenetics, which is the way environment affects the way genes work. So example, if you're a smoker, you can turn on bad genes. If you're overweight, you can turn on bad genes, different things like that. So, but yes, right now, gene therapy would make the most sense for people that we know have a gene disorder, so we know where to attack. But I don't think right now that story has ended, and we're going to be smarter about it, I think, in the future. But a great question.
Yeah, there's so much to learn. We actually, about 3-4 years ago, participated with some of our colleagues up in Toronto on a whole genome study. And we were doing full genome sequencing on a number of patients with HCM to see what else was in the background. It's a very slow moving project. I haven't gotten any results out of it yet, but there are things we don't know, and you don't know what you don't know until you know what you don't know.
Yeah.
And that's the complicated one. So Caroline, for what percentage of HCM have a genetic known cause? So 40%-ish?
So it's about 40% right now. We can discover with current contemporary gene testing have a single gene disorder. That's correct. Yeah.
But the
And-
concept would be, though, ultimately all of them will have a genetic basis. We just don't know all the mutations, and there are de novo mutations from time to time. Is that not true?
Correct. So it may be that the panel right now isn't robust enough to check all those mutations because we don't yet know everybody's mutations. And I think the other part of it is we're discovering that there are patients that have multiple genes and not just one. Now, the fact if you have a genetic test that's negative, it doesn't mean you still couldn't have a familial inherited disease. We're just not yet smart enough to know all the genetic mutations. So we still want families checked, even if your gene testing, quote unquote, is negative. That doesn't get you and your family off the hook, so to speak, because it still could be a familial inherited disease for which we don't yet on the panel know what your gene mutation is because you have a special one in your family.
Which is one of the reasons I really don't like the term negative. It is a no mutation found test, and nothing means nothing. We don't know. So
And that can be, it can be confusing for patients when they get a negative genetic test. We need to take the extra step to say that just means we're not smart enough to know your mutation, but it still could be an inherited disease.
For example, I have a gene of unknown significance, but it's very clearly a genetic disease in my family, multi-generational.
Right.
So there's that answer you can get as well.
Yeah, great. Yeah, there are so-called variants of unknown significance, which are variations in the gene code that we have not yet connected to disease, but we do review those, and these gene companies actually periodically send us those results. And I've had a handful of patients that had a VOS years ago that now we've discovered is either negative or is actually a positive gene causing mutation that causes disease.
Okay, a couple more questions because we're catching up from the last ones. Regarding ICDs, what is the relationship between getting a myectomy and needing an ICD if you didn't need one before? Can you explain why there is sometimes a need for a pacemaker after a myectomy? And what is the difference between a pacemaker and an ICD, Dr. Bartlett?
All right. There's about 6 questions wrapped up into one. The first thing to talk about there is, I think, useful, the distinction between a pacemaker and a defibrillator. I think of it as a defibrillator basically as a 2-function gadget. It is basically a pacemaker with a shocking function. A pacemaker's goal is not to provide termination of a cardiac arrest. It is to supplement the heart's native conduction system when it is damaged for some reason. That's another way of saying it provides stimulus to the heart muscle to contract in a regular, normal pattern such that the patient has no idea it's being done. Pacemakers are more commonly implanted in the general population than defibrillators. The second, my memory of the rest of the question had to do with the myotomy and myectomy. Myectomy simply resolves the obstruction surgically. It removes the thickened part of the septum so that blood can leave the heart without being subjected to high pressures to push it through. There are times where a myectomy results in damage to the conduction system. It turns out that the place where the surgeon has to make his incision and the removal of muscle, by the way, the term myotomy and myectomy are doctor words. It just means cutting of the muscle and taking it out. The M&M results in damage to the conduction system so that there is a block or a break of the electrical pulse traveling from the upper to lower chambers. In other words, the upper chambers and the lower chambers may beat independently of each other. If that's the case, then the patient needs some sort of device to restore upper and lower, what we call synchrony, so that the atria, upper chambers, receive the normal initiating pulse from the body, and that the lower chambers follow the appropriate interval so that the heart's coordinated. In some patients, simply a pacemaker is enough because they're not thought to have high risk for sudden death. They don't have enough fibrosis or other criteria that Dr. Zenker will elaborate for you in great detail and has for me on occasion. On the other hand, if we think that the patient has fibrosis or other indication for sudden death prevention, we'll implant a dual chamber defibrillator. And by the way, that's one of those cases where the 2-wire defibrillator is necessary. In that case, the defibrillator acts as both a pacemaker and a defibrillator, coordinates upper and lower chamber conduction, coordination, and provides the capacity to send a shock if the patient requires that because of ventricular tachycardia / ventricular fibrillation. Now, have I, Lisa, missed parts of that question, or is that all?
I think you covered it beautifully, to be honest. And the follow-up question I'm going to share with you and some of the answers here. Andrews is asking, is the research being done to improve algorithms for shock, lowering voltage, number of shocks, etc.? That's part one of the question. And part two is that I'm talking too fast. He was quoted a 3 to 5% infection rate possibility during replacement. Will we ever win the war against biofilms?
Okay, so let me help you with those. The first part of the question, is research being done to lower shocks, energy, and so forth? Of course. But we have probably gotten the efficiency of these devices to a place where it's going to be difficult to make big changes. We may see small changes. Right now, the standard voltage the standard output in energy terms for a shock to defibrillate is about 25 or 30 joules of energy. Now you can compare that to an external defibrillator. When you see these TV shows where they're coming at the patient with 2 paddles and shock the patient back to normal rhythm, though they're applying 360 joules. So relatively speaking, it's about 1/10 of the energy required because the lead is inside the heart. That creates a very highly efficient situation. I have seen research that looks at shocks delivered at very low voltages for certain specific conditions. Typically with hypertrophic cardiomyopathy, we don't try to go there because the disorganization and the fibrosis in patients with HCM can be sufficiently advanced that it isn't safe to use the much lower energies. Now, the second question was, tell me, Lisa, the second part of that question.
So the second question, I'm going to jump in.
Infection, right.
Infection, yeah.
So infection is, sure enough, there are several strategies that we have for dealing with infection. The 3 to 5% infection rate for generator replacement, it's probably on the high side. I think it depends so much too on other factors of the patient's health. Now, you compare someone who's 85 years old with advanced diabetes and an ejection fraction of 15%, who may have kidney failure and is immunocompromised from the drugs they're taking for their rheumatoid arthritis. And you compare that to a 55-year-old who's had 1 generator and is now due for a second one, but otherwise is living a completely active, normal, and otherwise healthy life, and the infection rates are completely different. We use pouches these days, net bags that are actually absorbable, that contain antibiotics for the higher risk patients. So imagine, if you will, a piece of stocking, because that's what they look like, or mosquito netting that are shaped the size of the defibrillator. They're little pouches. They get placed on the outside of the defibrillator during the generator replacement, slipped into the pocket with the defibrillator, and then dissolve and disappear over about 3 weeks during the period of maximum infection risk. That is one of the strategies that we have to try to combat infection and generator replacements. There are discussions about research about impregnating the outer surfaces of the defibrillator cans with antibiotic, or if not antibiotic molecules, with substances that are resistant to the organisms attaching to the devices. Those are still in the research phase. Right now, we have these antibiotic pouches, and the data with them are very, very favorable. Once
So-
again, I think 3 to 5% would be high for someone who's otherwise pretty healthy. It depends so much on the background features of the patient. I will say that the data also suggests that if you get into your third or fourth generator, the risk goes up slightly. But we do not avoid the procedures because of that risk.
So I have been invited to participate at the end of the month in a 2-year process. It starts at the end of the month on implantable cardiac device infections and raising awareness, and also triggering patients to take action earlier if they suspect an infection. So I will be down in DC, my first live meeting with cardiac kind of folks in a long time on March 25th to kick off this session to discuss what do patients really know, what do they need to know, what do we need to do better to help educate people about infection risks and mitigation of infection and all of that stuff. So I will probably be coming back to the community asking for some input on communication tools and things on that nature. But it's a hot topic at the moment. And I think we all can agree that minimizing infection risk is the best thing that we can do for everybody. I'm going to hold the rest of the questions for right now. We will get to them before the end of the night, but Anna's like waiting and like she's been chomping at the bit for like 2 hours now to get her presentation up, right? So Mark, do you want to introduce Anna?
Sure, yeah. Anna Rodonski is next. Anna is a dear friend and colleague. And if you look at her background, she went to Quinnipiac University and both did a PA studies and is a Bachelor of Science in Radiology. Uniquely, she also had a basketball scholarship at Quinnipiac. Although I think if we did 3-on-1 between Tom and Ron and me, I think we could take her now, but I'm not sure.
Yeah, I don't know.
Scholarship.
Girl power.
She was with Dr. Dan Jacoby at the Yale Center for several years, has a lot of experience in HCM and cardiac amyloid, and now serves as an instructor through Lipscomb University. And we have PA students coming through. And she's been very involved in research with Mabacampton, has been a really great resource for me. And Anna is going to talk about HCM and CHF.
All right. Well, thank you very much, Dr. Zenker. Okay, is that good?
Yes.
Perfect.
Looks good.
Okay,
Yeah.
perfect. All right. Well, first I would like to just say happy St. Patrick's Day, 7 days early. And here we go. So hypertrophic cardiomyopathy is the most common inherited heart disease in which the wall or the walls of the left ventricle are thickened and the heart has difficulty relaxing. This thickening is not related to other conditions such as valvular heart disease or high blood pressure. And HCM is not a rare disease. It used to be thought that 1 in every 500 people had HCM, and now it's as many as 1 in every 200 people. That would make 750,000 Americans having HCM, but obviously many of these are undiagnosed. Important to remember that hypertrophic cardiomyopathy is a treatable disease, and it's consistent with normal longevity as long as there's a timely and accurate diagnosis, sudden cardiac death risk assessment is evaluated, and these patients are on appropriate medications and treatments that are available. It is commonly misdiagnosed as anxiety and asthma, and we're going to talk about that later. Get an EKG and an echocardiogram because the absence of a heart murmur does not rule out hypertrophic cardiomyopathy. This is a great illustration from the HCMA in the early days, and you can learn a lot just from these 3 pictures here. So I'm just going to go over some basic anatomy of the heart. This is the right ventricle, the right atrium, tricuspid valve, right ventricle. This is the septum or the wall that separates the right and the left ventricle. This is the left ventricle of the heart. This is the aortic valve here. This is the mitral valve. This is a normal heart with the septum measuring less than 1.2 centimeters or 12 millimeters. The next image is an example of hypertrophic cardiomyopathy. You can see that the septum here is thick. When the septum gets thick, the ventricular chamber gets small. So more than 1.3 centimeters or 13 millimeters is consistent with HCM. The last illustration is a great example of hypertrophic cardiomyopathy with obstruction. You can see that the thickness is so thick in this picture that the left ventricular chamber is even smaller. And what happens is that the blood has a hard time leaving the heart. If you look in the middle picture of HCM, you can see this big pathway here for blood to leave, go out the aortic valve and pump blood to your body. When you have HCM with obstruction, some of the blood leaves and some of the blood goes back through the mitral valve. This is the mitral valve leaflet here. Blood goes back through the mitral valve, goes into your left atrium, and the left atrium is not used to all of this volume and this blood, so it gets enlarged. And when the left atrium is enlarged, you're more susceptible of going into atrial fibrillation, and then atrial fibrillation can cause pulmonary hypertension, and that can cause congestive heart failure. So this is an example of a cardiac MRI. This is, the first image is classic septal hypertrophic cardiomyopathy, where you can see the thickness of the ventricular septum. The other image is an example of apical hypertrophic cardiomyopathy, where the thickness is not at the septum. You see this is nice and normal here, but it's rather at the apex of the heart. The important thing about apical HCM is that this sometimes can be missed, excuse me, can be missed on an echocardiogram. And if you see it on an MRI, it's very important. Two very important things have to happen. These patients have to have anticoagulation because thrombus or clot can form within that aneurysm. And also they need to be referred for an AICD because a left ventricular aneurysm increases your risk of sudden cardiac death. So this is a great slide from another presentation that I was involved in. It looks like a very busy slide, but the point I wanted to make is that there are many different diseases that cause congestive heart failure, both non-cardiac things and cardiac things. And cardiomyopathy is one of the causes of heart failure. Specifically, hypertrophic cardiomyopathy is associated with heart failure. So what is congestive heart failure? Congestive heart failure is a clinical condition in which the output of blood from the heart does not meet the metabolic needs of the body. And there's two types of CHF. There's systolic and diastolic. Systolic means the squeezing of your heart stinks, and diastolic means the relaxation stinks. Hypertrophic cardiomyopathy is mainly a problem with diastolic dysfunction because the muscle is thick and the heart has a hard time relaxing. So nearly all HCM patients have some degree of diastolic dysfunction. Systolic heart failure is present in HCM, but it's rare. It's less than 5% of patients, but we're going to talk about that more later. So what are the symptoms of congestive heart failure? Most commonly, HCM patients complain of shortness of breath and fatigue. You can also have a cough that's dry or hacking, or you can have a wet, productive cough. The cough can increase at night, or it can increase when you're just lying down on your couch in the evening. You can also develop lower extremity edema or swelling, abdominal distension or bloating in your stomach, and weight gain. So the manifestations of CHF in HCM specifically is like what we talked about earlier, diastolic dysfunction, thick muscle makes for the heart to have a hard time relaxing. HCM with obstruction, as I described in the first illustration, HCM with obstruction, if it's severe enough, causes the mitral valve to leak, causes the left atrium to become enlarged, causes more susceptibility to atrial fibrillation, which can then produce pulmonary hypertension and congestive heart failure. And then there's also systolic dysfunction, where the ejection fraction in an HCM patient is less than 50%. CHF is the most common manifestation of HCM in adulthood. So what is ejection fraction? Everybody wants to know, what's my EF? What's my EF? Well, the ejection fraction is the amount of blood pumped out of the left ventricle with each contraction. So a normal ejection fraction is 55 to 70%. HCM patients have what we call a hyperdynamic ventricle, where it's very vigorously pumping. Their ejection fractions are mostly 70 to 85%. So the left ventricle contracts well, but where's this blood going? It's not effective. So if the ejection fraction is 50% in an HCM patient, this means that they are really sick because they depend on volume. And these are the patients that get referred for an AICD and referred to the advanced heart failure team to think about transplant evaluation. As opposed to a patient that doesn't have HCM, if their ejection fraction is less than 35%, that's when they get referred for an AICD. So there's a very big difference in ejection fractions in an HCM patient and a non-HCM patient, and the indications for AICDs. So congestive heart failure, the differences in an HCM patient as opposed to a non-HCM patient. HCM, once again, diastolic heart failure, thick muscle, stiff, can't relax, EF less than 50%, you get referred for an ICD and transplant evaluation. Non-HCM patients are commonly systolic heart failure. Most of this is compared to patients that have myocardial infarctions or coronary artery disease, where actually the contraction of the heart is not good. These are the patients that typically have lower ejection fractions, less than 35%. They get referred for an AICD. So once you demonstrate some signs and symptoms of shortness of breath and congestive heart failure, where do we go from there? How do we determine how we're going to help you? So this is an example of, we refer you for what's called a right and left heart catheterization or an angiogram. The box on the top, this white box, is an example of what a right heart cath entails. This is a venous stick, either the femoral vein, or we use the internal jugular vein, or sometimes we even use the vein in your biceps region here. This catheter is thread through the right atrium, through the tricuspid valve, to the right ventricle, and then out into the pulmonary artery. As we're advancing this catheter, we're measuring the blood pressure in each one of these chambers and also in the pulmonary artery. If these blood pressures are elevated, that's consistent with congestive heart failure. So this is what a right heart cath includes. This is the bottom pictures are images of what a left heart catheterization includes. Some people get confused. Are you only going to look at my left coronary artery? No, left heart cath is the right coronary artery and the left coronary artery and the LV gram. So this procedure is done via arterial access. It is being done through the femoral artery in the groin. More commonly, we use the radial artery in the right wrist here. And the catheter is thread up the aorta or around the arch to the aorta. And we inject a small amount of contrast. This is an example of the right coronary artery. This is an example of the left coronary artery with contrast in it. This blood vessel here that runs down to the front of the heart is called the LAD, or left anterior descending. You can see these little tiny squiggly lines here. These are called septal perforator arteries. And this is important in case you are one of the few patients that require an alcohol septal ablation. So once again, the gold standard for septal reduction therapy is a myectomy, is open heart surgery. But if you have multiple comorbidities, if you have severe sleep apnea, if you're older, if you are morbidly obese, COPD, bad diabetes, then you might be a candidate for a septal ablation rather than a myectomy. But once again, the gold standard is a myectomy. This is an example of a catheter in the left ventricle of the heart. We inject contrast into the heart to look at the hyperdynamic left ventricle. You would also be able to see a left ventricular aneurysm here. This also assesses the amount of mitral valve regurgitation that you can see leaking through the mitral valve instead of going out the aorta to perfuse your body. So right and left heart catheterization gives us a lot of information of congestive heart failure, and also allows us to look at the arteries, because the older patients get, and the patients that have diabetes and HCM can also have coronary disease causing HCM. So now we know that you have congestive heart failure. How do we treat this? Well, we treat it with diuretics, or commonly called water pills. You have to be very cautious if you have obstructive HCM, because you don't want to dehydrate these patients too much because they're dependent on this volume. At the end of the day, we tell our patients we want more out than in. We want you to urinate more than what you're drinking. Don't think that you're going to get dehydrated because you're urinating so much because you're on your diuretic, and then drink more, because then you're just defeating the whole purpose of the diuretic. The other thing to treat heart failure is beta blockers, because that allows the heart to relax and for the heart to fill more better, I guess, improved, I guess. And also you should be considered for upgrading your AICD to a biventricular device if that's appropriate. And another device that's very useful is a CardioMEMS device. And this is really good for patients that are difficult to manage, meaning their clinical exam doesn't really correlate to the degree of heart failure that they're in. This is a device that's implanted in the pulmonary artery. The procedure is done exactly like I just described on the right heart catheterization, where this device is deployed into the pulmonary artery. There are 2 nitinol wires that suspend it, and there's a little sensor in the middle. And what the patient, so this gets deployed, you go home, you get a special pillow. In the morning, you lay on this pillow for about 1 or 2 minutes. It transmits your pulmonary artery pressure to the heart failure team. And then they can call you and say, hey, your pulmonary artery pressure is high today. Take an extra diuretic pill. So this is a very useful device that can help manage difficult patients. And lastly, it's very important to evaluate all of our patients for sleep apnea, because untreated sleep apnea can cause a lot of havoc. So finally, we have some pearls. Pearls for the patients with HCM. Persistent shortness of breath is concerning. Please communicate that with us. There are many options, many different beta blockers and treatments available. One beta blocker may be good for you and not good for another patient. So we need to remember that you're all different and we need to help you, and we are here to help you. Remember that HCM is a dynamic disease. You're going to have good days and bad days. If you're having a bad day, remember to hydrate and fill up your tank. But there's also a fine line in HCM where in the beginning, when we meet you, we could encourage you to hydrate yourself and stay hydrated. And then maybe you become one of those obstructed patients, or you become, your diastolic heart failure gets worsened. And then you may turn into a patient where actually needs water pills and diuretics to keep the fluid off. So it's very important as an HCM patient to know where you are on that scale. And once again, it's beneficial for all patients to have a sleep apnea study, because the risk of pulmonary hypertension increases with untreated sleep apnea, and pulmonary hypertension is also related to HCM. These are the pearls for the primary care providers. Most importantly, not every young patient with palpitations or chest pain is anxious. Not every young patient with cough and shortness of breath has asthma. Think about HCM. For 1 second, just think about HCM. Get an EKG and an echo before prescribing Xanax and inhalers to these people. 1 EKG or 1 echo can save a gazillion lives, because all you do is diagnose 1 HCM patient, and then we have to bring in mom, dad, brothers, sisters, and children. So 1 patient, you just need 1 to help a lot of people. Get a good family history when you first meet a patient. The family history of sudden cardiac death requires a deep investigation. So refer these patients to us. Let us figure it out. You're the key to the early diagnosis, and we count on you. So what are the pearls for the HCM providers? Focus on improving the quality of life of our patients. Every patient is different. Metoprolol may be good for you and not good for you. Good communication is very important. Be prepared for the future. Many different things are on the horizon. It's an exciting time. And physical examination does not always demonstrate congestion. We've had a couple of patients just recently struggling and brought them in for their right heart cath, and wow, their pressures are really high. So don't hesitate to move forward with a right heart cath or a CPET, cardiopulmonary exercise treadmill test. And don't forget that HCM patients can also have coronary disease. we get a lot of stress echoes, but sometimes you need a little stress MRI in there, or nuclear stress test to identify patients with coronary disease causing their symptoms as well. And also celebrate being a provider in this exciting time of HCM, because the first time I saw HCM was when I was 17 years old as an X-ray tech recording the hemodynamics in the cath lab. And, now this is many years later, and it's super exciting to be a part of the HCM community and the research that's being done to continuously help our patients. And finally, I don't think that an HCM presentation is complete without Dr. Eugene Braunwald. So this is a photograph that was taken in Boston at the HCM Summit. And my heart was pounding, and it was definitely one of the best days of my life. Thank you very much.
I too have had the Braunwald moment where you're like, oh my God, I'm with Braunwald. Oh my God. For those who aren't completely aware, I'm going to show you something that was completely unscripted. And Anna, I don't know that you've ever even seen this. Oh, we're going to unshare your screen.
How do I?
So some of you may know that Dr. Braunwald, do I have the book here? Dr. Braunwald wrote the foreword to the book Dr. Marin and I wrote. But this is a letter that Dr. Eugene Braunwald wrote diagnosing the very first patient ever with hypertrophic cardiomyopathy. September 18th,
awesome.
1959, written to Claude Brady, diagnosing him, signed by, look, his autograph. And when I had dinner with Claude Brady in June of 2020, he gave me this. He said, I want you to have this letter. And I said, I will treasure it. I will keep it safe. Right now it's in a Ziploc bag on my desk because I'm not quite sure where I want to put it because it's so special. I don't know what to do with it. But Mr. Claude Brady passed away in January. He was diagnosed in 1959 in his late 20s. He transplanted in 1988 and he lived until 2022. There you go.
My hero.
Amen.
Yeah.
Yes.
Well, it shows you what good care can do to people with HCM, right? They can live long lives, and
They most assuredly can.
Yeah.
And it's never a dull moment, as we've seen tonight. But that was a great talk, Anna. That was really people hear the word congestive heart failure and it seems like doom and gloom and it's all downhill, but it's a bumpy little road that goes up and down, and you balance it and you learn your body, and some of those get worse and then they end up like Amy and I with new hearts, but most of them can be managed through these episodes and can be managed over life and have more good quality of life than poor quality of life, with good communication, smart teams working together, good analysis, and responsive patient and provider. It's that marriage of the two.
Yeah.
So bravo on that. I'm going to see if there's any specific questions. Oh, we have a long one there. We have a lot of Mabacampton and myectomy questions. I'm going to hold them till the end. If there's any questions specifically for Anna, let me know. So yeah, when I found out Anna was leaving Yale, I went, what do you mean? Like, where are you going? And she's like, well, I'm going to go with Dr. Zenker. I'm like, oh, okay. You're still mine. I'm good. So that was a couple of years ago.
Yeah.
couple of years ago.
Yeah, I am super fortunate from my past and super fortunate for Dr. Zenker. And yeah, I'm very grateful. Yes.
You got a great team there. Okay. So I don't see any specific, no, apical myectomy questions. Okay. We're going to hold there and we're going to get to a first here at HCM Bighearted Warrior Tour. We have somebody from the psychiatry discipline to come speak with us tonight. So Mark, would you introduce our next speaker? And I'm very interested in this talk. Then I'll give my abbreviated talk at the end and then we'll do Q&A.
Yes, we are fortunate to have Dr. Ron Salomon present tonight, and he has been a great resource for mental health and psychiatry in our group. And his resume is impressive, as all of the speakers have been tonight. He went to college at MIT, postgraduate work at University of Connecticut, and was on academic appointment there. He was also had an academic appointment at Yale, Vanderbilt University Medical Center, University of Arkansas. He has published over 50 peer-reviewed articles, written 11 textbooks, and has been very, very productive. And now we're fortunate to have him as a psychiatrist in Nashville, Tennessee. And Dr. Salomon is going to talk about coping with HCM.
Thank you. Ron, you're on mute.
Thank you very much. Thank you, Mark. Let me get my slideshow up. That should be showing the full slide. So,
No slides yet.
no slide.
Green button on the bottom.
Yeah.
It's one of those kinds of nights, I'm just saying. There you go.
Okay.
There you go.
Very good. All right. So I'm going to introduce just some ideas about how to think about HCM, and when you're thinking about it, how to cope with it, and then build some resilience using help from people around you, from the community, the medical community, and if necessary, from the therapy community. Most people kind of feel that feelings are something you don't talk about. You just keep them locked up. This is an old New Yorker cartoon. This is the barn where we keep our feelings. If a feeling comes to you, bring it out here and lock it up. That's really not the best approach for a number of reasons. You want to feel in control of your life, like these race car drivers. You want to be able to understand what's going on. And knowing about HCM, all the lectures, I've learned a lot tonight, really does help you feel in control, because then you understand some of these feelings that you're having, and not just that it's anxiety. As Anna was saying, the primary care providers have to be aware that not all anxiety is just in the head. The heart and the head are strongly connected. You want to understand things that you can do to help you, yourself and your heart, and then who to contact when you do have questions. And if you're watching this seminar, you're obviously availing yourself of some of the experts. You want to understand treatment options and be able to discuss them and ask questions. And then keep in mind that teamwork, this strong community of your family, people around you, the professionals, and the peers that we have in peer groups through HCMA, all help promote resilience. So the other part of it is that you can actually help your heart by dealing with the emotions. Emotions are improved if you do your regular walking and exercise. This is a major recommendation in psychiatry, that people keep active and do exercises as recommended, obviously, by your doctor. Keep your daily sleep and eating habits as regular as you can. That's very important for your mind and your emotions, and that helps your heart too. And then different things for different people, breathing exercises, religion, prayer, spiritual, all these things, mindfulness, yoga, meditation. These practices, whatever works for you, can be very helpful and calming for your entire system, including for your heart. And then, if needed, some therapy. sharing emotions is hard, but there are peer-to-peer support groups, and then there are professional counselors who can help you start to find your words and talk about your stress. And that takes some of the stress off your heart. So emotions are hard for a lot of people to start to express. They're very personal, and when you're not used to using the language, it's very hard to do. It's not something we're taught in kindergarten, talking about how we feel, although kids growing up these days have much more attention paid to it than people of my generation did. You have to decide in your own mind or with the help of people around you, what do you want to share? How much? Do you want to talk about the symptoms, the pain you might be feeling, the diagnosis, the experience of having the diagnosis, the treatment choices as they're developing and as they're explained, the costs of going through all these procedures, and then the doubts, did you make the right decision? The fears of making the decision, and then what to do when it's time to talk with your family about the genetic testing. These are all very stressful things. And you want to decide how much and what are you ready to share? Just things that are absolutely necessary, like you tell your boss that sometimes I may need to be out, so I need my Family Medical Leave Act in place. Or do you want to talk about more complex problems with certain people too? There are a core group, your partner, your physician, your therapist, the clergy, then immediate family and close friends, the HCM peers. Different choices are going to be made about who to share things with and share what things with. And how you do that may evolve over the course of time. When you do, excuse me, when you do look for therapy, there are a lot of things when you go Googling and looking for therapist, you'll find all kinds of things, and it's hard to tell what's best for me. So basically, there are several levels. There are people who are basically college trained, and they can be very good therapists. They have additional training beyond college usually, but their primary degree is a college degree. And they can help with basic things like anxiety and depression. When the therapist goes further for additional training, sometimes they're masters in social work, and you'll see their names followed by things like LCSW or Masters of Education, Masters of Science, Masters of Divinity. And they may be prepared to do more specific therapies. And then the highest level gets to be the PhD psychologists and so forth, the doctoral level in education and other things. And these people can really handle very complex patterns of emotional interactions. So the supportive therapy, it may sound like something that's very simple, but a good supportive therapist can be very valuable in helping you explore your emotions and helping deal with a new onset of feelings of sadness and anxiety. If there's a history that's more complicated with trauma in the past, that's in the presence of HCM and other things, somebody with more sophistication may be more helpful. I usually recommend that people who are brand new start with somebody at a basic level and see how that goes and move up to more costly approaches if really necessary. Another kind of provider in mental health is someone who prescribes. So you may see a nurse practitioner or an MD. There are also the osteopaths. And these are all people who can prescribe medications. Medications that we use range widely in how they work and what they do. Primarily, the benzodiazepines, Valium and lorazepam and so forth, may be very calming and they're quick, but they can give you some dizziness and drowsiness, and there is an addiction potential. Antidepressants, there are a very wide variety of antidepressants. Some of them are quite safe in patients with HCM. Some of them may interact with drugs like verapamil or propranolol. And the clinician really needs to know a bit about these interactions in order to prescribe them safely. The antidepressants don't just make you feel happy all of a sudden. They are more permissive in the sense that they seem to help people enjoy things if they're doing fun stuff. But you've got to be doing some fun stuff for them to really be able to work. And then you notice, oh, that was fun. I want to do more of that. And the depression starts to lift. It helps you, a lot of antidepressants will help with restoring the rhythms that I was talking about earlier, where your eating habits and your sleeping habits are very important to mood. Mood stabilizers are a bit more complex and they're very good, but they're going to be used in fewer and fewer people as we're going down this list. The mood stabilizers tend to make it so that if there's something that's upsetting, your rise time, your response time is quieter. It's more on an even keel with what most people would do. It's not meant to really slow you down, but it can help contain situations so that you don't become very reactive. And then tranquilizers, the major tranquilizers are probably even less commonly used in these situations. They can have side effects of their own that can be difficult to manage with the heart, and we have to watch out for blood pressures. So, but they will help if the thoughts become extremely intrusive, if there are hallucinations or thoughts that are abnormal. And they tend to be quick acting and long acting, but they will slow down thoughts, and they can have side effects such as tremor and other things. So their use is more for the practitioners who have more experience. There are so many different drugs. I can't possibly start listing and saying this one's good, this one's not. It depends tremendously on the individual situation, the individual symptoms that are present, and the medicines that are being used for HCM, and how these medicines might interact with it. I'm going to keep it brief and hope there'll be some questions that I can help with. Thank you for your attention.
Thank you very much. I think that was a great start into a very important topic for our entire community. And I'm hoping that we continue that path going forward. I want to just dive into here while anybody's asking some questions, and then I'm going to go give my talk I was supposed to give earlier. We're just going to hit some highlights, and then we'll get back to the bigger questions. So knowing when, I'm going to turn this one on its head a little bit. Many people who have HCM were told, you have anxiety, that's why you feel your heart race. Or they were told, well, the reason why you don't want to go out and do things is because you're depressed. So you get the ones who are told that it's mental health issues when it was cardiac. And then you have the other group of people who they have the cardiac diagnosis, and they're also dealing with symptoms of anxiety and depression. And sometimes it's hard to separate them from what is physical and what is emotional and what is chemical. And are there any great suggestions in terminology or words that patients use that are helpful to clinicians to understand, is this originating here or here or here? Is that question make sense?
So that's a great question. With experience, I fly by my gut a lot. I'll see people come in who have tremendous anxiety. And by the way, and I listen to them and I say, okay, what's been going on? When did this start? I get a history about how the symptoms evolved and which came first. And then I might refer someone to Dr. Zenker and say, hey, this one doesn't feel right. There's something funny going on here. The bad news is that I'm probably not referring enough, because my hit rate, and this is true for other illnesses too, GI and neurology issues and so forth, people are sent to psychiatry often. And it's like, no, this one's not mine. Let's go back to the medical field and really get a better workup. Medicine is an extremely complex environment. There are so many diseases with an incidence of 0.01% that who can expect to really catch them all as a primary care provider. As a psychiatrist, when somebody comes to me with psychiatric issues, but it's not really holding together and doesn't fit a psychiatric pattern, I start to look back. But I'm trained in psychosomatic disorders, and this is a basic part of what I've done through my career and taught through my career. So it's very, very intuitive for me at a certain level. I wish there was a single thing that stood out that I could say, if you have this and not that, then this is the kind of disconnect. But it's pretty complicated stuff.
It does start a lot with just being willing to talk about it. And we've been bringing it up a lot more here. And even in a recent podcast, one of my physician guests broke down and said, you know what, I've been to therapy. I have used these services. Life is hard. And when you have HCM on top of all of the other things that go on in life, it's a lot. And it's okay to ask for help. And after a night like tonight, I think I need to visit with a therapist, because here I am talking HCM and then it invades my actual life. And my entire family will be a little off kilter for a few weeks after this thing, because it's brings back all the other memories, and it's hard in an HCM family to process all of that. I see Amy shaking her head along with a diagnosis of herself and others and family. Yep. So there's lots of triggers. There's dates. There's experiences in the emergency room. There's experiences at a doctor's office. There's the smell of an emergency room. There's all kinds of different triggers for different people. And I'm just hoping that we can talk about it enough and get people to go out and ask for help.
I think one thing, I just want to make a comment about what Dr. Salomon said. So I think this speaks to this idea of experience, like Dr. Salomon mentioned. I think it's best for patients to go to a center of excellence, to go to a practitioner that has experience with these issues, because it is difficult to tease out what is anxiety, what's depression, what are cardiac symptoms. And it depends on each patient's unique physiology, what's going on with their heart. And I'm like Dr. Salomon, sometimes I'll listen to patients and figure out their triggers and realize that this doesn't sound like this is all cardiac related. And that's when I like to use a resource like Dr. Salomon. But I think, again, as a patient advocate, going to a HCM center of excellence where somebody has experience with these different entities, I think you're going to get better care than you're going to a place where they just don't have the experience with a complex HCM patient.
Mark, could I throw out a comment? There is no more stressful situation for an HCM patient than one who just got a defibrillator shock. It is a terrifying experience, certainly the first time they have it happen, but maybe every time. And one of the, beg your pardon? Sorry? Yeah, well, anyway, one of the things that a center of excellence can try to do is provide some sort of structure for receiving the data that someone's been shocked, to get phone calls from patients saying, look, this just happened to me, what do I do? That's more likely to occur in a center of excellence. It's less likely to occur in a smaller outfit where they just don't have the bodies or the expertise to handle those kinds of events. We also, without wanting to toot our horn too loudly, we have people in the office all the time with people on call all the time to handle those kinds of things if they happen. Moreover, there's electrophysiologists and other people in the EP department who are happy to have patients come in on short notice if a patient gets a shock and needs to get it reassurance that it was appropriate, A, and B, that the thing worked the way it was supposed to. There's a lot of insecurity and uncertainty and all that. So while we're not psychiatrists, we are frequently dealing with the question of how do we help people who have just had a pretty traumatic event occur. One of the things that we try to do is to explain to folks what to expect if it ever happens. What do they do? What does it feel like? What should you be concerned about? At what point do you call the ambulance immediately? And at what point do you sort of dust yourself off, but you can wait because you're otherwise okay? Those are conversations that should be held. And as part of I did not go into that with my presentation. I glossed over the intake conversations, but the fact is that should be part of the EP doctor's intake conversation with the patient.
Excellent points. Excellent points. Okay, I'm going to hold off on the rest of the questions, and I'm going to jump into some quick HCM announcements here, and I'm going to fly through mine because I want to get to these guys. I typically start with mine so everybody populates, but there's some important stuff going on I need to share with y'all. Now I got to move my little boxes around here. If you have not taken the poll yet, I will wrap up my talk with the poll. I typically start with the poll. So you can still take the poll and we can figure out why you're all here. So again, my apologies for the wonky start this evening and the leaving you unattended. Well, you were attended, but not by me. So I just want to thank everybody who's participated in the agenda tonight, and we're going to get to the Q&A and in a few minutes, and we'll wrap up that night. I do want to go backwards on my slides and say thank you to Boston Scientific, Invitae, Bristol Myers Squibb, and Cytokinetics for being our sponsors of the Bighearted Warrior Tour. It's because of sponsorship that we're able to bring you these events on these platforms and hopefully help you gain education and knowledge and understanding of HCM. And you know how to reach us if you need to. I want to bring to your attention a great program that started a couple of months back and is just starting to get out and running. It's called HCM Academy. It is a professional education process where we have developed a 6-module online learning system, 5 case studies with HCM warriors from you-know-who from our community. And these case studies are really good examples of how complex HCM can be. So this is meant for community cardiologists, general practitioners, family docs, pediatricians to get a better understanding of HCM and when they should be referring to higher volume programs. If you would like to participate in this program, I'm going to show you how to do that. If you want your doctor or your local community doc, GP, anybody to participate, you can give us their contact information and we can invite them to take the course. They do get CME credits for it as well. And it's a really great program. So there's 6 online CME courses, 5 online CME case studies, and then there's non-CME patient perspective videos, which are, some of them will make you smile, some will make you laugh, and some will make you cry. So I encourage you to go take those. But the unique part about this experience is there's an online learning module where they can join into a session with a medical provider who is knowledgeable in HCM, and they'll go through the slides with them and they'll answer questions on a one-on-one basis or 1-on-10 or however many are in the meeting. But it's a great program. So it's called the HCM Academy. Yours truly is a faculty member along with Marty Marin, Anjali Ellens, and John Lynn Jeffries. So that again is funded by Bristol Myers Squibb, Sanofi, and Cytokinetics. They provided the funding, we provided the content, and that is a great partnership with industry where they're letting us do the good work, and we are all working towards helping people understand HCM better. So if you want to go to the HCMA website and go under programs, you can find HCM Academy there. It'll bring you to a sheet like this. You refer your provider, you are a provider, and you can sign up. Very simple and helps people learn about HCM. So on HCM Awareness Day, which if you forgot to look at the million emails we sent you during February, was February 23rd, and next year will be February 22nd. We will now have the last Wednesday of February as official HCM Awareness Day. So you have a whole year to plan, people. Plan now, never too soon. We have launched a survey in partnership with the American College of Cardiology. If Julie and or Amy could drop that link in the chat, that would be great. The survey is open until tomorrow. We did 2 weeks. I went a little longer to get tonight in. So hopefully a few more of you can take the survey. What we're hoping to do here is, in partnership with the American College of Cardiology, we want to develop better educational tools, not only for patients, but for healthcare providers. And the best way to educate healthcare providers is to get information directly from HCM patients on what their needs are and where we can do better. So please take your time to fill this out. My goal was 1,000 in 2 weeks, which was a little ambitious. We're at about 600 right now. So come on, if you're listening, please, we do a lot of work for you here. It's about 12 minutes of time, answer the questions, and let's see how close we can get to 1,000 in 2 weeks. Thank you very much. Legislative advocacy is going to be a major feature of the next 24 months of the HCMA's work. We are looking to do something that sounds quite simple, and if we can get the right ears in the right state houses, it will be simple. It's logical. We want every well child examination in the United States to include cardiac components. Right now, only New Jersey does it. So we want to ask about family heart health history. We want to ask about symptoms, and we want to educate providers on what they're looking for and when to refer to cardiology, not only for HCM. Yes, we called it the HCM Act because we're the ones who built it, and we came up with a cute name, which actually is the Healthy Cardiac Monitoring Act. It's a very logical piece of legislation. It should be budget neutral. It's nonpartisan. Everybody has a heart, so we can all agree that we should do better at finding those who have diagnosable conditions. So it's HCM, it's long QT syndrome, it's Brugada syndrome, it's ARVC, it's dilated cardiomyopathy, it's Marfan's, it's congenital defects. We're looking for all of it. But if we start with asking some basic questions, that opens the door. And we provide the training. In the state of New Jersey, we have an online module, and you can take a course, you get a certificate, and you must show that certificate to the payer community so that you can be reimbursed for your well child examinations. No certificate, no reimbursement. There's the trick. So they have to take the education, and they do their well child exams, and they become educated. So we're looking to pass that legislatively through multiple state houses. We've made it really, really easy. It's called 3 clicks to save a life. You go to the website on HCMA, you say HCM Act, you click 1. 2, it brings you to a software called UJoin. You don't need to know that. But that is a system where you plug in your name and address, and it automatically sends it to your state representatives, your assemblyman, your senator, your governor, your what's the health department, whatever that position is that I just can't think of the name of. So it goes to all the right people, and you can write your own letter as to why you think this is important. Additionally, you can make a little video, and you can send a video to them. So make it really, really personal. Hit a button, and it's in. We're going to be having training on March 22nd with our partners from Women Heart, who do amazing legislative work. So they're going to give some legislative training on some of the things that they've done and some tips that they have. And then we're going to give you some more actionables on the HCM Act. We're also going to start having call days and call nights where we'll all collectively get together in a Zoom room, and we'll target a state. And we're going to call every representative in that state, leave messages, send emails, and make sure they know about the act. And we'll go state by state. You don't have to live in the state to participate, but you can set, we'll have a constituency list with numbers that the HCMA represents X number of people in your district. And we're going to have you help us with a fun call night. So we'll all be on the phones together. HCMA staff will be there to help you answer questions. If you don't know what to do, we're going to be right there with you doing it. So look forward to that. Please sign up on March 22nd to learn a little bit more. And we're really excited to get that program up and running. So I'm going to give you a little recap. This is hot news right off the presses. So HCM Awareness Day was a really big success. It was a little chaotic, and I will not do it the same way next year because yours truly was live for 8 hours here on a Zoom room, and it was a little much, but we got a lot of content out. We got a lot of traffic. We also were able to do a media tour about a week and a half, 2 weeks ahead of HCM Day, which dropped throughout the month around the country. And we had over 27 million viewers or listeners to our media pieces. We had over 44,000 visitors to the site on a particular day. That's a lot for our small community. You can see as Heart Month ticked on and we shared the amazing stories of our amazing warriors, the traction built and built and built and built and built. So people are paying attention. People are learning what HCM is, and events like HCM Awareness Day really help. So stay tuned for next year's, and you'll see how you'll be able to get involved, share your story, tell your story, update your story, and we will be able to spread more awareness about HCM. I'm not going to spend a lot of time tonight talking about centers of excellence, other than to say I will be visiting this one, and I'm going someplace else soon too. I'm going back up here. So there's another New York we're looking at. There's Colorado. There's Tennessee, not Tennessee. It's actually it's Memphis down in the corner, Le Bonheur. So we're going down south, and we have a lot more to do. There are 17 programs currently under review by the HCMA to become centers of excellence. It is important that there is quality care within a reasonable distance of every American, and frankly, everybody in the world, which kind of puts me into another conversation, which is HCMAI, which is this new logo over here that might be new to some of you. We are working with patient groups or helping to form patient groups in Sweden. We're working with an established group in the Netherlands. We're working with partners in Australia. I have a meeting next week with Japan. We're working with a wonderful patient who's a physician in northern India who wants to do outreach to Bangladesh, Nepal, and Pakistan, I think it is. So we are starting to plant patient advocates in parts of the world that never had patient advocates. And we're aligning them with physicians in the region. And we're rebranding our poster into the language that is native. And we are this is world domination, people. This is HCM world domination. We are going to help people literally no matter where they are. Our traction to our website right now reaches on a monthly basis over 100 nations. It's translated. Thank you, Google Translate. So we need more outreach to the world to help them understand HCM, and we're doing it piece by piece. These are our Facebook communities. So you're on the Facebook page if you're watching that part, but we have smaller groups where we have discussions. Okay, the smaller group is like 8,000 people now, maybe not so small anymore, but it's where you can have individual conversations with other patients that don't show up on your news feed. Additionally, we have these other groups that are breaking out that are the Swedish language group and the Dutch language group. I'm also working with Italy. I forgot Italy. And Canadians, come on, you're just like Americans that like the colder weather. So we all kind of talk together. So that's okay. So the Canadians tend to be in the American group. If you have not joined an online discussion group yet, I encourage you to do so. You meet friends, you talk about HCM, you can commiserate a little, you can learn a little. We have great volunteer moderators who run these groups every week. You should never be more than 48 hours away from a session, so you never have to feel alone. And these programs started a little over a year ago. It was a COVID creation, and they've really come on strong. And now we're having groups regularly with 18, 20 members a couple times a week, and they're always different people and always different topics. We have themes of the month. March is arrhythmias and living with an ICD. So that's kind of where we keep the themes on the thread of arrhythmias and how it feels and the emotional aspects of dealing with arrhythmias. So we kind of cover it from all angles. Tales from the Heart. Tomorrow is Marty Marin. Harry Lever is every other week or every other month. Steve Bauman joined us for the first time last month. And then I have monthly guests. And I have some unique ones coming up, including a young man who came to know the HCMA when his mother called us many years ago, about 10 years ago. He got a myectomy, went off to college, became Dr. HCM patient, and now works in an HCM center. So we've taken it full circle, and he's going to be joining me quarterly for insights from the patient working behind the veil. So I think that'll be really interesting. That's with Alex. So I'm really excited to start having some conversations with him. We're also going to be building genetics knowledge. So we're going to have sessions starting in a couple of weeks, once a quarter, through the Bighearted, not Bighearted Warrior, through the Tales from the Heart programming, where we're really want to help build people's understanding of genetics. I'm sorry, Mark, I'm going to go back and listen to your whole talk later, but I know you talked about the upcoming therapies. We understand autosomal dominance. We know kind of what that means. We know familial, we get that. But we're going to build everybody's knowledge so that when and if, and I think it's a when, not an if, genetic therapies become available, everybody has a good baseline to start with, and they understand where the targets are and what we're exactly doing, so that when a clinical trial becomes available, you can make a good decision whether it's right for you or not. So stay tuned for that. Invitae is still providing their Detect program, and that is free genetic testing for anybody who has a diagnosis of HCM and then their family members as well. You can get the information on the HCMA website. It's a fantastic program and very high quality genetic testing. I will answer a question that's in the queue. How often should you get genetic testing? How often do the panels change? They don't change that regularly. If you've got it done in the last 3 years, you're probably up to date with our current understanding, but you want to check in occasionally. I'm also on another task force about variants of uncertain significance and how the lab community and the clinician community are dealing with this issue. So we're about to publish a white paper on this, explaining what we think the best practices are for industry, for patients, and for physicians. And we're going to see what happens with that. This is an NIH-sponsored committee that I've been on for 4 years now. And it's a really hard question. How do you go about variants of uncertain significance reclassification? Whose responsibility? Who's paying for it? Where does the relationship start and end? So these are really important questions that we didn't know we had to ask until we got here. And now we're asking them and clarifying that. So stay tuned for some information on that. And that's almost all I have for tonight. And I have a typo here, and I'm so sorry to my friends at St. Luke's. It says University of Iowa. I was in a hurry. So sorry. Thank you to all of our Center of Excellence partners, our staff, our board, and Brandy, my donor, because without her, I would not be here anymore. So please be a donor. And lastly, there's a lot of chaos going on in the world right now. And I know the news is really hard to hear, but I just want to, on behalf of the HCMA, send our thoughts and prayers out to the people of Ukraine. And we all pray for peace and an end to that conflict. So I had to say that. I just feel terrible about the whole thing, like everybody else does. So I'm going to stop my screen share, and I'm going to give you the poll results real quick. Ending the poll. I think it's the longest poll I've ever had up. It was up for 74 minutes. Thank you to all who participated. So I'm going to share the results. Most of you are from the Northeast or Southeast, so that makes sense. Some from the Midwest, from the West, and we've got a Canadian or two present. Why are you here? 92% of you have HCM. 8% has a close family relative. 8% is from industry. And we have somebody who's just curious person. Welcome. We don't have enough just curious people. What are you dealing with? So 25% were diagnosed in the last 2 years. The most stressful time for somebody with HCM is the first 2 years. You're learning a lot. 67% of you are on medication. 33% have had a septal reduction. 33% are in AFib. 8% have lost a family member to HCM. 50% have had genetic testing. 17% have been advised to have an ICD, but have not done so yet. And we have nobody looking at myectomy, although one of the questions said somebody was debating a myectomy. So that's who's here tonight. And I'm going to pivot to some questions and stop talking so much. So I answered Connie's question about genetic testing. Does anybody have any other comments on how often you should repeat genetic testing?
No, well, it depends on the disease, but as it relates to HCM, yeah, I think every 3 to 5 years is my practice. And it depends, of course, what changes occur, but yeah, I think every probably 3 years is reasonable.
Okay,
Can I ask a question regarding that?
sure.
I just was curious of, those who have a gene of unknown significance,
Yeah.
what happens with that? Like,
So-
go ahead.
So what happens with that now is that the genetic companies that do these tests periodically review all the VUS patients.
Mhm.
And not uncommonly, we are then contacted by the genetics company that says either the VUS is now maybe negative or that the VUS is now positive and now it's actually a pathogenic mutation. And then if that's the case, then of course we contact the patients, we have a conversation about what that means. I think I've maybe only had, I do a lot of genetic testing. I probably had maybe a handful of VUSs that have come back. Remarkably, we've had 2 in the last month that actually, both which I knew clinically had HCM. One was a younger woman who was thinking about having a family, and her VUS is now turned into a pathogenic mutation. So that's knowledge and power that's important for her. So we had her come in and talked about what that meant. But yeah, the standard has been with most of these companies is that these are reviewed and then we are contacted as practitioners if the status changes.
Okay, thank you so much.
Yeah.
Okay, excuse me, some other questions. I have HCM, I have SICD, told my gradient's getting worse. Okay, so told gradient getting worse and heart getting thicker. So first I'm going to pause here and I'm going to ask Dr. Zenker to comment on imaging outside of a center of excellence and what the variability is in wall measurements and how gradients can be transient in nature. Can you touch on that a little bit?
So as far as the first question, as far as quality of imaging is really important. If it's a bad quality echo, either it's a patient that's hard to image, or if the machinery is not very good, both of those can give incorrect results or inaccurate results. So I think it is important to, as most of us do in the HCM world, have a standardized echo protocol. We have standardized measurements. We always do what's called Valsalva, an exercise to try to elicit gradients because some of them only occur with activities or with Valsalva. And people's phenotypes and thickness can change with time. And we do have occasional patients that have been stable for years and then develop worsening LVH, worsening relaxation problems, diastolic heart failure, and their gradients change and their symptoms change. The thing to realize about gradients is that, like Annie had said, that's a dynamic process anyway. Your gradient depends upon what you had to eat, what you had to drink, what medications you're on, when you took your medications. So not uncommonly, if we did an echo and measured your outflow tract obstruction 2 days in a row, they're going to be a little different. And that depends upon all those factors. But we look at also then with time, what happens to that? And if people have worsening symptoms and worsening obstruction, then we may have to change their therapy and or sometimes do invasive therapy.
So high volume center of excellence with consistent imaging and consistent reads probably is helpful here.
I
to
would
make
agree,
sure
yeah.
that patients get consistent information. And if in doubt, have a reread of your imaging, like bring the actual disc to a center, let them do another image potentially, balance the two, see what's real, see what's not so real, and go slow. I always tell people, don't rush to any invasive procedure. Make sure you know exactly what you're dealing with before you sign that consent doc.
The other thing, just as to discuss with that, is advanced cardiac imaging is really important, meaning a cardiac MRI. So I think everybody who's diagnosed with HCM should have a cardiac MRI. And if you look at data comparing MRI measurements versus echo, about 30% of the time, the echo was incorrect because, in part, an MRI is just a better picture. MRI is also uniquely set up in that it can look for myocardial scar, which no other test can. Really important for predicting sudden cardiac death and arrhythmias and major adverse cardiac events. And if anybody is looking at invasive therapy, a cardiac MRI is very, very helpful for surgical planning, because not uncommonly people have thickness in different areas of the heart. They have abnormal, what are called papillary muscles. These are structures that connect the heart to the mitral valve. And all that needs to be known about before a surgeon can do a correct surgery myectomy that may not be the same for everybody.
Can I chime in one quick word there too? You get your MRI before you have your defibrillator implant.
Yeah.
The defibrillator will ruin the defibrillator, the MRI's capacity to analyze tissue at that level.
Well, so I agree with you, although there's a couple of issues with that. And as you know, most devices now are MRI compatible, and it is best to get it done beforehand. But if people have defibrillators, we can still generally get a reasonable look at hypertrophy and fibrosis, albeit we do get some artifact. But yeah, just like you said, trying to get it done before your defibrillator would be key. But there are situations where if the phenotype changes, that we can still image if our electrophysiologists feel like, there's not a retained lead or some other reason we can't do that.
And I'm not suggesting that you shouldn't ever have an MRI if you've had a defibrillator. All I'm saying is if you've got some control over the steps, make sure it's best, you'll get the best study done before the defibrillator is implanted.
Yeah, I completely agree. That's a great point. Yeah.
I'm really glad you guys brought this up, because this has been coming up a lot lately. Patients who have devices, I can't get an IC, I can't get an MRI, I can't get an MRI. And that was the mantra for years. Studies came out about 1.5 years ago, and it's been evaluated for a long time that it is safe. And even, I'm a little antsy about this one, with abandoned leads, it's deemed safe to do an MRI now. So if you need one, you can get one, but you definitely should get good images before you device up. No doubt about that.
And you should have an MRI done in a facility that has a cardiology group that appreciates that can be done safely in most situations. Yeah.
The other piece on that is you really want to work with a center when at all possible for your cardiac MRI. In some programs, they'll do a cardiac MRI, but they don't have a protocol specific to HCM. They may be read by a radiologist who may not have a full appreciation for gadolinium scoring and all of that kind of stuff. So we definitely, I know I always sound like the center of excellence, spokesperson when I do this, but there is a reason, people. It matters. We've seen bad quality images. We've seen people waste not only time, but money. Your insurance company is going to pay for one MRI. Make sure you're getting it where you can get the best results, or you're going to be out of pocket, $3-4 grand for another one. So that becomes problematic.
Lisa, I'm ignorant about this. Do you require for Center of Excellence status that cardiologists read cardiac MRIs, or will you confer such status on programs where radiologists read cardiac MRIs?
We much appreciate a cardiologist read. There are some centers where it is it's conjoined, because radiology owns the magnet. So the radiologist will do the first read, but the cardiologist will do the second read. And they learn from each other, but we do prefer that it be done by For those of you who do not know the politics of cardiac medicine, who owns that MRI is a big deal in some centers, and who controls it's a big deal in some centers. So we like it when the cardiologists do the cardiac imaging, but sometimes radiologists get a little funny with us.
Yeah.
We like them, but we prefer cardiologists do the read.
I think one thing that's unique about our Center of Excellence and Dr. Zenker is that he reads echoes, stress echoes, does his own TEEs, does our own, he does the right and left heart catheterization. He reads the MRIs. I think that it is very important that that the images are done appropriately, and you also have a knowledgeable person reading all these images. And I think that that's something definitely unique to our program, is that he does them all.
And that's why the man doesn't sleep.
Sometimes that is true. Yeah.
Sometimes that's true. Okay, so pivoting from the do I need a myectomy based on a center saying yes and no, let's pivot that to an ICD question. And I'm going to use the exact language here because I'm going to play with it a little bit. Was told that a major center, now I don't know if it is a HCMA recognized center of excellence or if it's an academic medical center, that they needed an ICD. So I sought a second opinion that disagreed the need for the ICD because my risk was very low because I was diagnosed later in life at age 60. What do we think about one person says device up, the other one says don't? Dr. Bartlett.
Actually, I'm going to punt that to Mark, because Mark's the guy who really sends the patient to get the thing done. The fact of the matter is that there are better and better criteria for who should get one and who shouldn't. We're getting more and more data. A lot of it's MRI related. The fibrosis burden has become an increasingly important stratifying factor. But as I said, I'm going to task Mark to chime in, because really, I'm the operator, he's the decider.
Well, so we looked at several risk factors for the need of an ICD, and these are risk factors that increase the risk of sudden cardiac death. The problem is that it's nuanced, that there's no definite hard rules, but we do know a couple of things. One is, clearly, if you've had sustained ventricular tachycardia, ventricular fibrillation, or sudden cardiac death and you survived it, you should get an ICD. That's an easy one. We also know that family history is important. If you've had a family member, especially a first-degree family member who has had sudden cardiac death or has passed out unexpectedly and died, that's a risk factor. If you yourself have passed out and there's not a reason for that couldn't be related to HCM, that's a risk factor. We also, at least annually, look for arrhythmias. And if we see something called ventricular tachycardia, especially multiple runs, fast runs, these are individuals for which we should at least consider an ICD. We also know that imaging, like Dr. Bartlett said, is really important, which is why a cardiac MRI is so important. We know that people that are very thick, 30 millimeters or more, have a higher risk of sudden cardiac death. And we know that although most 2/3 of people with HCM have scar, the more risk. And it seems like as the scar burden gets higher, especially above 15%, there's about a twofold risk increase in sudden cardiac death. And we use that also as another imaging tool. And there's also a final imaging feature, which Annie alluded to, which is looking at a apical aneurysm. We know that people with midcavitary thickness and aneurysms have a higher risk of sudden cardiac death than those with ejection fractions less than 50%.
Go ahead.
As this person though alluded to, we also know that this is the one of the rare conditions that as you get older, your risk of sudden cardiac death actually goes down because you have lived for this many years and not had sudden cardiac death. Right. And Dr. Marin has published some pretty interesting data showing that above the age of 60, no matter what the other risk factors are, your risk of sudden cardiac death is pretty low, albeit people with an apical aneurysm, I think there's still a higher risk, even if you're above the age of 60. But I think in the end, we look at all these risk factors and we give us kind of our best estimate what that is. And it is kind of a nuanced opinion.
Let me throw one other thing in. I agree. Mark has hit it on the head. Those are the things we think about. There has to be a certain degree of personal comfort with the whole idea.
Yeah.
And I don't think I think that has to be emphasized. There are people in the world who really don't want to put off the idea of cardiac arrest. They don't think that it's such a big deal. If that's what happens to them, so be it, they're ready. I think the person that you've brought up who is getting two very different opinions is going to have a sort of a personal chat and ask himself the question, how badly does he want to be protected? And on the other hand, is he prepared to accept a little bit of risk? Usually when people get varying opinions from experts, it's because it's a borderline situation. It's not because one center's right and the other's wrong. It's because reasonable physicians can disagree. When you get to that point, my advice to the patient is to do a little bit of internal search and say, how comfortable am I not being protected? Would I just as soon opt on the side of being protected, putting up with the hassle factor that a defibrillator represents, or not? And there are people in this world for whom it's a bad decision.
There's another piece of this puzzle that is a little confusing. High risk, low risk, no risk doesn't exist. We know that. No risk is not a thing.
Right.
But the definition of where the lines are, I have spoken to people who were in the room at the time. There was not a great deal of science behind here. There were some numbers tossed out and they decided that 4% chance over a 5-year period was the line where you would go from low risk to middle range risk, and over 6% would be higher risk. So these are all very subjective numbers. Right. If to you, 3% is a pretty big shot, that's enough risk for you, then that's enough risk for you. You never get to zero. Nobody's at zero risk with HCM. It's about 0.5 is the lowest level. So we never are 100% safe, but we know who are in that medium, like that 4 to 6 and that 6+. And this is where shared decision-making is critical, but only if all parties understand what they're sharing. If we all have the same understanding and same degree of knowledge of what the risks are, and we have those discussions. I spoke to a gentleman a couple months back. He was in his late 80s. He has a great deal of scar burden. He's had HCM for as long as he can remember. And he also has the gene for Alzheimer's, and he's starting to lose his memory. And he told me that sudden death would be a blessing.
Exactly.
And I agree with him. Yeah. And he said, okay. And interestingly, Dr. Salomon had to leave, but this gentleman happened to be a psychiatrist with HCM at 88 and still practicing. But he knows he's cognitively not what he was. And he's making the decision that he's not going to get a device. And that's an appropriate decision for him. And you need to make those decisions with people who share your understanding and know what your goals are in life, and also know what your goals are in death. And we don't talk about that so much, but it's an important thing to talk about. Another paper I commented on for the Heart Rhythm Society many years ago was end-of-life decision-making with ICDs. These are complicated questions. You have to make a decision at some point, hopefully, when you're like in your 80s or 90s, that, okay, I'll turn off the defibrillator function, I'll keep my pacing function. Thank you. But it's a lifetime commitment with the device, and you don't want to enter into it lightly. So
yeah,
please.
I think that's why you, like Dr. Bartlett said, you have to know your patient, know your patient's goals. And some of that 4%, 6% was actually based upon something called SCUDHEF, which was a defibrillator trial, not even in HCM patients. Right. But you're right, like 6% to a 22-year-old would be different than a 6% risk in somebody who's 85 years old.
Exactly.
So again, having that conversation and honestly, these are risk factors, but like you said, there's never a zero risk in anybody with HCM. There's low and medium and high.
Yeah. I think also that I'm probably repeating something that you've already implied, but age has such a big role to play in this decision. The 25-year-old and even the 65, 70-year-old, very different lifetime risk. So that's where I will start. I start working through these other factors that Mark has enumerated, but the age is where I always start.
And I always have to bring up this point because we have lost a few to this next item that I'm going to bring up. You do not need to be symptomatic to be high risk.
Oh, absolutely true.
And that
exactly
seems
right, yeah.
completely contrary. It sounds like you're talking out both sides of your mouth, but we have lost a few who wanted to wait until a major life event, or I'll do it later, and they never get to later.
I think this is why we reinforce to families the importance of family testing, because a lot of people will say, well, my kids don't feel bad. And we say, but unfortunately, they're still at risk for sudden cardiac death. You're exactly right. So lack of symptoms does not take away the risk.
Exactly. Okay, we got a couple more questions, and then we're going to wrap up on Facebook in a few minutes. So to those Facebook people, if you're on there, because we got a whole bunch of people watching us on Facebook right now, if you want to come into the room, we're going to be here for another couple of minutes, and we're going to go offline, and we're going to ask questions without recording. So if you wanted to do that, you can still click the link and come join us. So I'm going to go into the Mabacampton myosin inhibitor myectomy question. We are likely on the brink of an announcement from the FDA regarding the ability for physicians to start prescribing Mabacampton. And I say likely because the FDA can do whatever the FDA wants. And if they don't want to do it, they're not going to do it. But we suspect that it's coming. Will somebody describe the mechanism of Mabacampton and how it works and what it will be used for first round?
So you may have missed the first part of my talk, but I talked about Mabacampton and the mechanism of action. So we talked about how, again, the HCM is a disease of the sarcomere, these little motors in the heart, and there are these actin and myosin pistons or filaments that connect and relax. And that Mabacampton works specifically on the myosin protein that basically decreases some of the aggressive connectivity that makes the heart too stiff. And at least in studies that have been done so far in both obstructive and non-obstructive patients, there seems to be improvement in symptoms. There's a signal that it might decrease things like the hypertrophy, maybe help the heart to remodel in a more positive way. These are very preliminary, I think, data. So we don't know if it really will change the disease process long-term or not. And getting to the myectomy question, so we are one of several centers in the US doing the Valor trial, which is a trial looking at Mabacampton versus septal reduction therapies in patients who have class 3 to 4 symptoms, have gradients above 50, and we're then comparing the two. So hopefully within maybe a year to year and a half, we'll have that data back and we'll know how Mabacampton compares to our gold standard, which is septal reduction therapy, especially surgery.
Okay, so now I'm going to be the killjoy a little bit here. If we look at the early data from Mabacampton and some of the Aficampton, so the cytokinetics drug, it works really well for some people, and it doesn't work for other people. Just like everything else in the HCM toolbox, it works for some and not for others. So there's a question here.
In fact, I showed a graph that you missed it, but that 43% of people, even on Mabacampton, still had gradients above 30, right? So it's better than disopyramide, it's better than beta blockers, but it's exactly right. It's not perfect for everybody.
And it probably has to do with where the mutation is located.
Yeah, right.
Could very well have to do with genes, and we're still waiting on all of that data. So this individual doesn't want to have open heart surgery because it's open heart surgery. Let's be real here. This is major surgery. Yeah. However, they want to wait for Mabacampton and they want to give it a try. I want to put a couple of pins in this one. Number one, you may want to try it, but there may be barriers to trying it. The label has not been written yet. We think you're going to have to go to a high volume center who's doing comprehensive HCM care to get the prescription. So a center of excellence. That's number one. And that's what we're hoping for the first 5 years of MAVA, that it's only prescribed by centers who really understand HCM. Because if everybody starts prescribing it, they're probably going to give it to wrong people. And then the drug's not going to look good because the wrong people will have gotten it. That's my personal position and the position of the HCMA. So that's part one, that's a problem. Part two, we don't know what it's going to cost. And we don't know what insurance is going to do. If you have private insurance, you'll probably be okay, because we've been working behind the scenes with BMS to create a patient assistance program that to the person who has a traditional insurance plan through an employer or purchased on their own, they would be able to use their insurance and then go to the patient assistance program. However, if you're Medicare or Medicaid, you're not going to be able to use the patient assistance program, and it may be cost prohibitive for you. We still have a lot to learn. I have a promise from BMS that as soon as we have a word from the FDA, we're going to have some very transparent discussions about this, like very quickly. And as soon as possible, I will be here presenting that information to the community. But not everybody's going to be able to get access to it in the first year to 3 years. It's going to take a while. So how do you feel? How high is your gradient? If you don't think it's bad, you really need to have a talk with your physician, with a family member nearby. Because if your family member is there, you're going to tell the doctor how you think you feel, and your spouse, family member, friend is going to tell them what really is going on. And you need that dynamic to make sure that you're not minimizing your symptoms so that you can avoid an uncomfortable 3 weeks of life. And that's what a myectomy is, an uncomfortable 3 weeks of life for most people. Your thoughts?
Directing it to me?
To anybody.
Yeah. So Mabacampton isn't FDA approved. We know what the data shows. There's no clinical experience with it. I do agree with the concept that there are a small percentage of people with Mabacampton that get their ejection fractions too low. So this drug has some risks. And for that reason, I think it's going to be important that this be given with somebody has experience with that, is at an HCM center of excellence, because this drug can help people, but it also has some risk. And we want to make sure that the right people get it. And that if there are any signals towards too low of an ejection fraction, that of course that drug is suspended or stopped.
Exactly.
Myotomy and myectomy has been around for so long, and we have such robust data with results from that, especially in the hands of surgeons who do a critical number of cases, that it's going to be very hard, I think, for the foreseeable future to tell somebody that Mabacampton is as good as a myotomy myectomy. We may find there will be patients where that's the case, but boy, myotomy myectomy has been tried and true, and there are patients where it may be a marginal recommendation for myotomy myectomy, where the gradients may not be quite as big, but for patients for whom the operation was designed, it works well.
Oh, I completely agree. I mean, in the right patient with the high gradients who's still symptomatic, it is remarkably rewarding for patients and for doctors. And there is some data, although it's not randomized data, that it can even extend lifespan. So those are all great things.
Apical myectomies.
Yeah.
This is one of these ones that we all kind of go,
Yeah.
because there's not a lot of data. There aren't a lot of patients who've had it.
Yeah.
There are a couple different reasons for this. Some surgeons get deep enough from the traditional approach, and some want to go through the apex. But when it comes to an apical aneurysm, can you treat that with an apical myectomy, or are you looking at it at an aneurysm resection, which is a little different than a myectomy? How do you manage?
So there's a couple of different things. So apical HCM is a different entity than an LV apical aneurysm with a mid-myocardial gradient. So they're different phenotypes. That's one thing to understand. As it relates to a true apical HCM, and these are people, again, with hypertrophy in the tip of the heart or the apex, there are some individuals that have such robust LVH and they have such low cardiac volumes that their cardiac output of their heart is very, very low. And in that particular patient subset, an apical myectomy does work, albeit it's not the standard. There have been some places, Mayo Clinic has published some things on this, so has Cleveland Clinic. We have done some apical myectomies, but these are specifically in patients with low cardiac outputs for which if you do a apical myectomy and open up the chamber and get better volumes, that can help that particular patient, but that's a small subset. Then there's a separate entity of somebody who has an LV apical aneurysm. We generally, if they're not going to get surgery anyway, we generally, there's no data to advocate doing LV apical aneurysm resections. Now, we've had several patients. We had one this week who had LVOT obstruction, mid-myocardial obstruction, had an apical aneurysm, was highly symptomatic, had very high mid-myocardial and LVOT gradients despite beta blocker, calcium channel blocker, and we took him to surgery and did a extended myectomy, had the surgeon open up the LV apex, do a mid myectomy, and then resect the aneurysm. And so if people need surgery anyway, and they're going to get that done, we always tell them maybe there's a reason to go ahead and resect the aneurysm, more so in people that have residual clot. If you are on anticoagulation and there's still residual clot, it makes sense to consider that. Whether that mitigates the sudden cardiac death risk in those patients by doing that, we really don't know. And right now, if I get like this particular individual that had an apical myectomy, we still are advising that he get an ICD because we don't know if there's still going to be VT around the zone of that aneurysm. But these are complicated cases for which you want to, again, be at a place that has experience doing these kind of things.
I need to pause here for a second and say, did you see what he did there with that thought process and how articulate he was? That's what he did when he was a row behind me in the conference. I'm like, who are you? Where did you come from? And how do I not know you yet? So I completely geek out and listening to Mark Zenker chat about HCM.
Oh, Lord.
I know. It's almost like a Braunwald moment. Like, oh my goodness, he gets my world.
And he's getting nauseous.
She'll keep you in line. She'll take
I know
you
she
right
will.
back down tomorrow morning. You got this. You got this. Okay. So anonymous attendee, it would be good if centers of excellence had supportive therapy practices there, because not all of them do. You are completely right. We are working towards that model day by day, center by center. It is a new concept for cardiac care to be thinking more supportive and to think beyond the heart. The cardiologist's job is to take care of your heart, but we're trying to change the narrative that HCM centers should take care of the whole person. Mind, body, and soul all work together. And when they are working together, that is where you get the best outcomes. Life is hard. HCM is harder. Combination of all of the factors, we are really working towards that day. We have some big ideas coming up in that space, but it's going to take a couple of years to bring them to fruition. So stick with us and watch us continue to grow and help to develop those programs and maybe provide some support programs to centers that don't have on-site supportive therapy. So stay tuned. I'm not done yet, people. I got a new heart a couple of years ago. The first 25 years were awesome, but the next 25 years, just hold on. So not that I give myself much more work, but we have an awesome team, so we can do it. Activity in HCM. So the Live HCM study is about to kind of put out some more data. Is there any data to suggest whether exercise or endurance activities would worsen progression of disease?
So the story with exercise and HCM, we're a whole lot smarter now than we were before. Initially, I started practice 25 years ago. We told people not to exercise because HCM could get worse or could manifest sudden cardiac death. We know that's really not true with moderate exercise, because the flip side is we have then people getting sedentary, becoming obese, getting diabetes, hypertension. So I think what's been shown more recently is that moderate exercise is safe and is beneficial in patients with hypertrophic cardiomyopathy. We still, I think, as cardiologists, debate if there's an athlete with HCM. Most of us are very conservative about advising them to not be a competitive athlete, albeit there's some debate now about what to do with those people. But as a general patient, modest and moderate exercise, we advocate, is very safe to do so and is highly recommended.
And your defibrillator will not inhibit you from doing moderate exercise, just in case you were concerned.
Yeah.
I put up a picture of snowboarding and fishing. People do all kinds of things with defibrillators. There's no reason that should hold you back.
Yeah.
Amen. Thank you for that. Okay. Exciting news about Tenaya. This person calls it a game changer, and I'm going to use the word potential game changer. When will we see potential commercialization? Oh, honey, slow your roll. We haven't even done a trial. Okay, so we have a long way to go, and we can't get this one wrong. This is going to take a while. My guess would be 5 to 7 years, realistically.
Yeah, so that company, Tenaya and this Lexio, both have mouse models, basically, where they have shown that in mice that these treatments are highly effective and safe. But yeah, we're not even in the human realm yet. So I agree. I think we're looking at least 5 years, but I think it's something that is exciting. It's a potential great therapy source. Like you said at the start of this, if you're a patient and want to be part of a trial, and if this comes to fruition and appears to be safe, I'd keep an open mind to it.
I would say the same. And to our dear friends on Facebook, we are closing out, and we're going to take a couple more questions here for a minute. So thank you for joining us on Facebook. Adios and good night.